and welcome to our Department of Medicine's Grand Rounds. On behalf of the Division of Geriatrics and the HRSA, the Brooklyn Initiative to Develop Geriatric Education, it is my honor to introduce our speaker for today. Our speaker for today is Dr. Dharmarajan. Dr. Dharmarajan is the Vice Chairman of the Department of Medicine, the Clinical Director of the Division of Geriatrics, and the Geriatric Medicine Fellowship Program Director at Montefiore. He is also a Professor of Medicine at Albert Einstein College of Medicine, Brooklyn, New York, and he's an adjunct professor of medicine at New York Medical College. Dr. Dharmarajan is a former professor of medicine and associate dean at New York College of Medicine, Valhalla campus, and he's the chair of the Department of Medicine at Our Lady of Mercy Medical Center until his recent transition to Monty. Dr. Dharmarajan is certified by the American Boards of Internal Medicine. He's also certified in nephrology and geriatric medicine. And he's also a fellow of the American Geriatric Society. He has masters of the American College of Physicians and fellow of Royal College of Physicians. Dr. Dharmarajan was instrumental in developing a very reputable inpatient geriatric program at Our Lady of Mercy Medical Center in the Bronx, currently Montefiore Medical Center, with clinical, academic, and research components, including a fully accredited fellowship program, which has 10 geriatric fellows. Dr. Dharmarajan has also co-edited textbooks, the textbook of clinical geriatrics and the textbook of geriatric gastroenterology. In addition, Dr. D has authored and edited approximately 200 publications in peer-reviewed journals and textbooks. He has over 500 scientific abstracts and presentations locally, nationally, and internationally. He has been a principal investigator for several research projects, including a national multi-center study for the AMDA Foundation. He has won the Howard Gutterman Award for Best Research Project in the National Annual AMDA meetings. And more recently at Monty, he received the first prize for Best Clinical Science Paper. He received a Lifetime Achievement Award at New York City in April of 2019. And in the same year, he received recognition for leadership and community services from Monty. Dr. D. Dharmarajan is instrumental in teaching and mentoring young physicians. Some of his many recognitions in medicine include Teacher of the Year, peer-to-peer recognition by the Bronx County Society, dedication as teacher and mentor to young physicians in the Bronx, and unparalleled leadership in medical community for medicine and research. In 2003, he was featured on the cover of Aging Well magazine, and he was featured as one of the 5 noteworthy geriatricians. So in terms of his accomplishments and in terms of his awards and honors and recognitions, I can probably easily spend the next hour talking about Dr. Dharmarajan. So without any further delay, it is truly my esteemed honor to welcome Dr. Dharmarajan to today's Grand Rounds, and we're looking forward to his presentation.
Thank you very much, Dr. Prosper. And I thank also Dr. Reinhardt and Donovan and the 2 chief residents, all for working with me and putting up with my requests and the difficult things that I have asked in order to prepare for this presentation. When I was asked to speak on this book, the title is Geriatric Gastroenterology, which is going to come out within days, within the very early part of next month, about 2,400 pages and 3 volumes. I did not know where to begin and where to end. So I have called it a selection of pearls, and I'm going to try to see what I can do in terms of the time that we have at our disposal. I'm sorry for the little confusion at the beginning of the talk, but let's hope the rest will go smoothly. So no conflicts. I will not repeat the objectives which have already been stated in my paperwork earlier, but my plan is to give you a brief introduction to aging, and then we will go on to more selectively problems relating to the gastrointestinal tract or system in relation to older people. So number one, we need to know that it's not that the GI tract, but all of our body declines in its function as we go from the 20s or 30s when we peak, and I'm sorry to tell you that, towards older age. So essentially, a shrinking of what we call as function or reserves. We are fine at rest, but when we are faced with difficulties, such as the stress of illness, we find it hard to cope. We also therefore become vulnerable to disease. This shrinkage is termed by some as homeostenosis. When one dies, eventually, it's wrong to say he died of old age. Most of the times, there is a cause of death. If you're perfectly healthy, you can live on to become a centenarian, and the centenarians are actually on the increase in this country as well as worldwide. And the super centenarians is the hardest number to attain. From 100 to 110, it's very difficult. And the super centenarians are not just going up in number, but they are far fewer. If you look at the nature of the illnesses that cause death, the most important is heart disease. But the more striking fact, and this is from our CDC data, is the dramatic decline in heart disease over the last 20 to 30 years. This is amazing. And this is due to all the preventive measures we are taking. So the hospitals prepared for a lot of beds for an increasing number of heart disease as the cause of illness and hospitalizations, but look at what has happened. We have not done as well as heart disease in terms of cancer. There's a little decline, but as you get older, cancer is bound to occur from changes in your cells. The decline in heart disease is matched for stroke. So the two vascular events decline. So what is it that we finally die from? A lot from influenza and pneumonia, both preventable, yet many die for failure to do the basic steps like taking the vaccine. We die of something else known as Alzheimer's disease. It's about number 6. As you live longer and longer and longer, there's a higher and higher likelihood that you can get Alzheimer's disease. We have yet to find a good preventive method for Alzheimer's disease, nor a cure. When you go further down, what is not visible here is accidents, driving accidents, or accidents from falls. The American Geriatric Society has stated 5 M's as to what matter to the patient and what we should keep in mind. And in your evaluation, you recognize the patient's mind and emotions, the ability to move, because failure to do that impedes everything that this patient wants to do, the medications which are entirely in your hand, the importance of recognizing a multi-complex disorder invariably in most, and finally asking a patient a simple question: what is it that matters to you? I'm going to do all this, but what matters to you? And that's really what you need to address. It doesn't matter what you attempt to do, but it should matter to the patient. There's going to be a huge, I would say in relative terms in this talk, importance given to medications in terms of how much polypharmacy is rampant in terms of our day-to-day practice, and what is now known as deprescribing to address polypharmacy. When you communicate with the patient, make it simple. Have a bright room so that the patient can see you. Remember, most patients have a problem with hearing, and many have a problem with vision. You don't want glare on the patient's face, but you want a bright enough room they can see you. Speak loudly and clearly. Having a mask these days is actually a hindrance because they can't read your lips. You need to keep that in mind. The patient may not hear you at all. And if you repeat a sentence, use different words, not the same sentence over and over again. And if that fails, you may have to consider writing. We all think older patients complain a lot, and that's really not true. In relative terms of how ill they are and how many disorders they suffer from, if a brand new patient comes to me, at the end of the visit, I would be able to easily say that if the patient is 70 or 80, they have at least 5 to 6 problems at a minimum, and maybe more. They are not aware of their illness. They are sometimes in denial. They think everything is due to old age, which is not true. As I said, it's more due to a medical or surgical or other forms of illness, a psychiatric illness. It's illness rather than age. There's a high likelihood of cognitive disorders and depression. They're afraid to come to you because of cost, and they believe that nothing can be done or they will end up in the hospital. So one of the first things you should do, irrespective of what specialty you practice, it doesn't matter whether you're a surgeon or a physician or a cardiologist, doesn't matter. you need to understand these two terms, capacity and cognition, and they are not the same. Capacity refers to medical decision-making capacity. So what is capacity? Can the patient understand you? Can the patient express a choice as to what this patient wants, appreciate what is being done, and reason as to what would happen if the choice was different? Hello, giving a grand rounds. Appreciate and reason. By reason, I mean, what would happen if this patient was not going to accept your choice, or is there an alternate? Is there a surgical approach, a medical approach, or doing nothing? Can this patient be consistent? And this term is different from the word competence, which we should hardly ever use, which is a legal term. But when you say capacity, you also need to figure cognition. And while I'm not going to speak to you on dementia, cognition means the process where you have existing knowledge and you use it, or you have the ability to acquire new knowledge. So it's existing and new knowledge, and using a bunch of processes, which are many. Memory, we all think it's memory. Memory is only one aspect. Can you recall? Can you recall what was being said in this lecture tomorrow? Can you add knowledge? Can you rationalize? Can you reason? Can you solve problems? Like we had a problem this morning with the Zoom. Can you solve it? All this is cognition. So capacity, a patient with mild dementia or impaired cognition can have capacity. We should not equate the two. Why should we screen for cognition? Because it's not recognized. Sadly, it's not recognized. I see that in the hospital many times in the interdisciplinary rounds, the staff is too quick to blame a patient. And I would often end up asking the question to the primary team, by the way, did you check the patient's cognition? And next day they would say, the cognition is grossly impaired. So I would say, now go to plan B, and that is to ensure that you deal with someone else or a caregiver to handle this patient's insulin dosing. Because they were stating that this patient was not adhering to treatment. So that is a consequence. A consequence of cognitive impairment is non-adherence, and the result of taking medications without a proper basis, adverse events, the proneness to a confused state or delirium, and the burden to everyone, to the caregiver and to the society. A cognitively impaired patient could drive and get into a car accident, and that's a burden to society. So all this happens, and you need to recognize that cognitive impairment is extremely common as you get older. This is the simplest means to check cognition. And if you have to know one test, at least understand the mini-cog. It's often asked in the exam, if you have to have a large gathering of applicants to a program or to a school or college, and you want to check cognition, what would you do? This test would take less than 5 minutes, 3 to 4 minutes. You mention 3 words, 3 different words. Example, a pony, a dollar, and an apple. 3 different words. Repeat it one more time to make sure the patient heard you properly. And then say, I'm going to get back to you on these 3 words. Ask the patient to next draw a clock, a simple clock. You're allowed to draw the outline of a clock and give it to the patient if you wish. Ask the patient to place the numbers, place the time at 10 minutes past 11 or 20 minutes past 11, and see whether the needles were placed in the right areas and the clock was overall correct. So 3 items. Now you go back and ask the patient, what were those 3 words I just mentioned? If the patient got all the 3 words correct, that's the end of story. The patient is cognitively intact. If the patient got none correct, the patient likely has dementia. If the patient had 1 or 2 correct, you need a perfect clock. So that's how you kind of score the patient, and you can decide. This is a very sensitive test for cognitive impairment. And if this is giving you a score that suggests dementia, you have to realize that everything you're going to do for the patient from then on, irrespective of your specialty, has to be taken with the fact in mind that this person may not be able to exactly determine what is right or wrong for this patient. And that goes back to capacity. In mild dementia, you can have capacity, but as your dementia progresses, capacity will be lost.